The Global Surgery Lab presents below-the-knee amputation. The goals of this video are to identify indications for a below-the-knee amputation, demonstrate an approach to this procedure, and outline the key principles of post-operative management. The goal of the procedure is to remove unhealthy or damaged tissue to reduce pain and create a remaining leg that will increase the patient's ability to carry out their daily activities. Indications for an amputation below the knee may include trauma, tumor, life-threatening infection, and vascular problems of the leg below the knee that cannot be repaired. The general approach to a below-the-knee amputation includes 1. Applying a tourniquet and making a skin incision, 2. Cutting muscles and clamping the fibular artery, 3. Sawing the tibia and fibula, 4. Completing soft tissue cuts and ligating vessels before removing the tourniquet and observing for bleeding, and 5. Approximating the skin flap to complete the wound closure. To perform this procedure, you will need a tourniquet, a knife, surgical clamps, surgical scissors, a giggly saw or bone saw, soft tissue retractor, a bone file, an amputation retractor, suture, and a surgical drain. Remember to follow all safety protocols and best practices. To begin, place the patient in supine position and apply a tourniquet above the knee. Plan your incision so that the longer part of the remaining tissue is on the posterior to provide a better blood supply and coverage to the open defect and bone. Next, make the skin incision using a knife, aiming for the stump of the tibia to be 8 to 15 centimeters in length. Next, cut the muscles of the anterior tibial and perineal compartment, separating the tissue from the posterior side of the tibia. Be sure to clamp the fibular artery. Next, use a giggly or bone saw to cut the tibia from posterior to anterior. Before cutting completely through the tibia, change your cut to a 45-degree angle and finish sawing the bone upward. Next, cut the fibula 1 to 3 centimeters proximal to the level of the tibia cut. Next, use a bone file to file the end of the tibia and ensure there are no sharp edges. You may place the tibia and fibula in an amputation retractor to protect soft tissue while filing. Continue to cut the soft tissue from the posterior part of the tibia and fibula. Cut the skin from the posterior aspect of the tibia to complete the amputation. Next, separate the deep and superficial muscles of the remaining posterior tissue and ligate the vessels. Pull the tibial nerve downwards and cut the nerve as proximal as possible in order to have the nerve buried in the muscle. Then, cut the remaining muscle. Once there is no bleeding, rinse the wound with saline and approximate the skin flap. If infection is not a relevant indication for the amputation, a primary closure is acceptable. Otherwise, wait 3 to 5 days for a delayed closure. Before performing the final closure, check for infection. Then, insert a drain and suture the subcutaneous and cutaneous layers closing the wound. Apply fluffy gauzes, pad bony prominences, and apply a compressive dressing that exerts even pressure on the soft tissues. The limb stump should be monitored for necrosis, bleeding, and infection every 24 to 48 hours post-op, and the drain should be removed around 48 hours post-op. In conclusion, a below-the-knee amputation can be done to remove unhealthy or damaged tissue, allowing the patient the greatest chance to resume carrying out their daily activities.